Hello everyone, my name is Kyori Kim, and I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce Hot of the Press. Twice a month, we'll be hosting Hot of the Press with one of the authors of latest APS paper and two panelists. It offers you a special opportunity to directly hear from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hello, everyone. Welcome to APS's Hot of the Press for March issue. Today, we'll discuss a comparison of outcomes in immediate implant-based breast reconstruction, acellular dermal matrix versus inferior dermal flap, written by Dr. Ribeiro and his colleagues from the St. Joseph Hospital of Portugal. And we're joined by Dr. Barbosa from EPO Oncological Hospital from Portugal as a panel. So no, without further ado, we'll have a discussion from Dr. Ribeiro. Sorry.
Let me just point out something, because this was the paperwork that we did. It was made with I'm the only one, actually. Me and one of the authors are from the St. Joseph. All the other ones are from IPO hospital.
Okay.
So hello to all the audience. My name is Luís Ribeiro, and I'm a plastic surgeon at Hospital St. Joseph in Lisbon, Portugal. Thank you for inviting me to present this paper as hot off the press. I would like to present a comparison of outcomes in immediate implant-based breast reconstruction, acellular dermal matrix versus inferior dermal flap. As you all know, immediate breast reconstruction is a critical step in reducing the psychological burden associated with breast cancer and mastectomy. In most Western countries, due to increasing rates of obesity, implant-based reconstruction in 2 stages is favored. In these patients, autologous reconstruction is more challenging, with higher rates of severe complications and morbidity. The subpectoral plane positioning of the implant offers a safe and reliable treatment, but there is a significant loss of lower pole coverage, breast projection, and inframammary contour. 2 solutions were implemented to overcome this problem: the development of ADM, a biologic mesh that provides structural support for the ingrowth of native tissue, and another solution was to the lower pole problem was the development of an inferior dermal flap. The lower pole skin that is usually removed during a wise pattern mastectomy is deepithelialized, creating a flap that will be sutured to the pec major muscle. This study aimed to compare the outcomes and the incidence of post-op complications between immediate single-stage breast reconstruction using ADM or IDF. A retrospective medical record review was performed for a consecutive series of patients undergoing immediate breast reconstruction at IPO Porto, the Portuguese Institute of Oncology, between 2016 and 2018. Patients submitted to skin-sparing and nipple-sparing mastectomy were submitted to immediate reconstruction with implant plus ADM, and patients submitted to wise pattern mastectomy had reconstruction with implants plus IDF, and these last group of patients had a grade 2 or 3 ptosis. We reviewed hospital records independently for all patients, collecting data on patient demographics and comorbidities, such as age, BMI, smoking history, diabetes, hypertension. And the outcomes assessed included major immediate complications, such as hematoma, infection requiring IV treatment, mastectomy flap necrosis, and implant extrusion. Also, early complications that happened within the first 6 months post-op. Also, length of stay, total breast drainage, reinterventions, readmissions, and need for implant removal anytime. The minimum follow-up time was 6 months. Regarding the surgical technique, about the ADM, after skin-sparing mastectomy, the ADM was used as an inferior sling for the breast implant. The infralateral margin of the pectoralis major muscle was released, and the ADM was sutured close to the IMF and the inferior border of the muscle following its lateral contour. The breast implant was then introduced through the central pocket, left open, and then placed below the pec major superiorly and the ADM inferiorly. And then this interface was closed with absorbable sutures. In case of a nipple-sparing mastectomy via inframammary approach, we opted to begin the reconstruction by securing the ADM to the pec major muscle initially. After this step, we would insert the implant inferiorly and then finally secure the ADM to the IMF fold. 2 drains were used, one in the pre-pectoral space and one in the subcutaneous space. Regarding the IDF, initially, the patient was marked in the upright position, like in a common Wise pattern incision. And then initially, the plastic surgeon began deepithelializing the lower pole skin, and the oncologic surgeons proceeded with the mastectomy through the neck area. After the mastectomy was done, the remaining incisions were performed, and the lower edge of the pectoralis major muscle was dissected, lifted, and then the retropectoral pocket dissected. The breast implant was introduced through the pocket between the muscle and the IDF inferiorly, and then after the implant was placed, we closed the muscle and IDF layers with absorbable sutures, and finally, the inverted T incision is closed over this autoderm surface. Regarding the results, a total of 85 women underwent immediate implant-based breast reconstruction. 73 women underwent reconstruction with ADM, comprising 101 reconstructions, and 12 women were submitted to reconstruction with IDF, totaling 17 reconstructions. Patients in the IDF group had a higher BMI than the ADM group, 27 versus 24. There were no other statistically significant results regarding demographics or comorbidities. Concerning the outcomes, in all of the several outcomes analyzed, there were no statistically significant differences in both groups. Regarding the discussion, one-stage breast reconstructions is nowadays commonly performed in many centers. The pec major muscle is dissected and sutured to the serratus myofascial component inferiorly, providing a well-vascularized cover, but a limited rigid pocket for the implant. So the use of the ADM and IDF allow surgeons to more easily cover the implant, cover the lower pole, create a natural ptotic shape capable of more expansion and so more projection, and avoiding dissection of the serratus fascia or muscle. IDF reconstructions are performed in women with large ptotic breasts. ADM can also be used in this context. However, in a thinner woman with smaller breasts and limited ptosis without excess skin, IDF is not possible since there is not enough tissue to create a dermal sling inferiorly to cover the implant. In our study, there were no statistically significant differences in the outcomes. Dr. Han et al. In a study published in PRS Go in 2017 also compared both of these techniques and also did not find significant differences in the outcomes. But importantly, in this study, the authors used a 2-stage approach. So initially an expander placement and then change of the expander to a definitive implant afterwards. Despite this, in our study, the ADM reconstruction group had a higher rate of implant removal than the IDF group. We believe there are some differences regarding the nature of the complications that can explain this finding. Patients in the IDF group suffered mostly from seroma and marginal skin necrosis. since the IDF reconstruction provides a complete vascularized layer for implant coverage. Even if the skin does not survive, there is still a healthy layer of tissue covering the implant and making the extrusion less likely. On the other hand, in the ADM group, the most frequent complications were mastectomy flap necrosis and infection. These can lead to reconstructive failure. IDF has the advantage of keeping its own blood supply, preserving the inframammary fold attachments, and providing a thicker layer between the implant and the skin, contributing to a more natural consistency and feel. T-junction breakdown is common after wise pattern mastectomies. But when using the IDF technique, this critical area is directly over the vascularized dermis. And so it protects the implant, but also limits the skin breakdown. Consequently, even if the skin necroses and the IDF becomes exposed, it is still capable of surviving and protecting the implant with low rates of reconstructive failure. To conclude, our study suggests there are no significant differences in outcomes between using ADM and IDF in immediate implant-based breast reconstruction. In patients with large ptotic breasts, we recommend immediate reconstruction using an implant and IDF. The main benefits of the IDF are its easy availability, no additional costs, and exclusive use of autologous tissue. We recommend that a contralateral mastopexy or breast reduction should be offered to all patients who undergo unilateral reconstructions, since the conversion of a ptotic breast into a young breast shape produces a significant asymmetry in the breast shape of these patients. Thank you.
Thank you, Dr. Ribeiro, for a great summary. And then thank you for sharing your experience with us, because, I think direct implant these days is, became popular procedure for a lot of patients. And then, the way to minimize complications is important. The question I have for you is that I know that you mentioned on your paper that you didn't really measure the weight of a mastectomy specimen, but how do you determine how much of an implant volume to place? Sometimes if you place larger implant that's larger than the breast pocket, then you put mastectomy flaps on the kind of in danger for blood supply as well. So what are your tips that you could share with us? How do you determine what kind of implant to place? And then do you actually push your envelope on the patients who are having IDF versus ADM?
Mm-hmm. Well, I think the mastectomy weight, even though it was not recorded, it is always used during the intraoperatively. Another thing that's quite important is the use of sizers within the surgery, because you can use it as a test to measure what kind of implant you should use, and especially the size of the implant. Of course, in cases where there's a sort of lack of perfusion or expected lack of perfusion, that's even more important, so as not to inflate, so not to choose an overinflated implant. And so that's really important in my opinion. We have sort of expected volume beforehand, but obviously these intra-op measurements are critical.
Do you use ICG angiography, or how do you determine whether the perfusion is threatened with a sizer?
No, it's not common to use ICG, unfortunately. For us, it's not something that we have. We can use that commonly. So we have to basically just clinically check the flap, scratch the borders of the mastectomy flap, and then just base our decision on clinical signs. I'm not sure if Dr. Barbosa wants to mention anything else.
Yes, maybe related to the first question. We know that the breast that we want to reconstruct, it will be always smaller than the original breast, because you have a ptotic and large breast. We don't want to put there an implant that has the same weight then the breast we remove it. So most of times the breast will be smaller, and we will do a reduction mammoplasty in the contralateral side. Always we measure the basis of the breast, and we will not put there an implant that exceeds that basis. Okay, so it is important to not put much pressure on the flaps, even if we are not happy with the volume of the breast. We can always, in a second time, do some lipofilling. So the most important is have flaps that we can rely on. So it's more important than to have in the first stage the ideal volume. But I can say that the most of times we have a volume that is very, very acceptable and nice results. But always, or most of time, smaller than the initial volume of the breast. The second question, yes, we don't have, we only rely on clinical inspection to evaluate the viability of the skin flaps. We also can think if the flap don't seem that is viable, what to do. So in these cases, we have mainly two options. We can put there an expander, an expansor. Also, we can, in some cases, we can use the dorsalis flap to protect the implant and have a more reliable reconstruction. And we talk with patients before surgery if that scenario comes, what we should do.
Carrie, do you have any questions?
First of all, I thank Dr. Ribeiro and Barbosa for great work. I have a question. So in your paper, all is the subpectoral reconstruction. Do you have any experience using IDF, inferior dermal flap, for the prepectoral reconstruction? I understand we cannot cover all implant surface with the flap, but I think we can decrease the amount of the ADM, and plus we can use like ADM plus inferior dermal flap. Do you have experience with that?
I haven't got any particular experience using ADM and IDF at the same time in a prepectoral plane. At least as far as I know, the series that have come out, the largest series that have used the prepectoral plane, usually the patient selection is very critical. So usually young patients, they don't allow smokers, BMI very controlled. So this is in a very selected group of patients. So to minimize basically the risks, which is understandable. But I don't think it's useful because it's for our kind of population, usually higher BMI, a smoking rate, which is not that low actually. And so I think it would be quite risky. I know nowadays there's even only ADM like Braxton sort of devices that cover the entire implant, but still, if the mastectomy flaps are not that well perfused, I think all these techniques will fail ultimately because there's no vascularized layer beneath. So if there's no vascularized layer covering the implant, sooner rather than later you'll have a problem.
I see. I have one more question. So I can expect the statistically there's no difference, but we can expect the marginal flap necrosis will be higher in a group with the inferior dermal flap. Do you have any special post-op care or management to decrease the risk of this necrosis?
I'm not sure if Dr. Barbosa wants to.
I have some pre-op and post-op care that I think can help in this issue. Preoperatively, I think it is important when we do the design of the wise pattern to not do the 90 degrees around the nipple, just the minimum that is necessary to take out the areolar complex. Because if you do the 90 degrees, when closing, you put more tension. So if you do less than that, we'll have less tension on the flaps and on the suture. Another thing, we start using the 7 centimeters in each vertical arm, but you can, for example, use 8 centimeters because the skin will retract, and when closing, you have less tension. Another thing in the post-op period, I'm now using vacuum device dressings in the sutures, and from a preliminary point of view, I think that can help in the cicatrization and the viability of the edges of the flaps.
Literally close the wound and apply back.
Yes, a vacuum dressing.
How long do you leave it on?
This is new. The patients we have in this study, I didn't do that, but recently I'm doing that, and I believe that is also a step that can help in the cicatrization, even in the seroma, diminishing the quantity of seroma and the dyes with drains, because I think that favors the cicatrization between the layers.
Interesting.
I also wonder if it helps with the ADM sticking to the skin flaps, because sometimes you go back and ADM hasn't incorporated, so it might help with that as well.
Yeah.
Well, I think, it was a great discussion, and then thank you very much for sharing your tips and the pearls from, doing, it's because it's such a, difficult reconstruction to the implant-based reconstruction direct to implant. It's really great to hear, the experts from your experiences as well. Thank you very much for joining us today, and thank you everyone for listening this Hot Up the Press for March issue. Thank you.
Thank you so much. Bye-bye.
Thank
All right.
you. Thank you very much for joining this fantastic discussion. Be sure to tune in for other articles we'll be discussing on future Hot Up the Press. You can also connect to the Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We are looking forward to meeting you on our APS social media.